Welcome to another episode of Le Coin des Experts. Today I'm very pleased to have here with us Dr. Brad Leech. Dr. Brad Leech is a PhD qualified clinical nutritionist and herbalist specializing in chronic autoimmune conditions and complex gastrointestinal disorders. Brad has taught and developed subjects at leading universities and conducted research on intestinal permeability, autoimmune disease management, and food-based probiotics. Brad is the lead clinical educator at CoBiome by Microba, and he offers practitioner support through his multiple microbiome mentoring programs. In this interview, we'll talk about intestinal permeability, its definition, its prevalence, the main contributors. We'll talk about inflammation, recommended tests, favorite nutrients to help with intestinal permeability, which are the worst enemies, the role of pre and probiotics, and Brad's take-home message. As a reminder, everything that is discussed in this interview does not intend to diagnose or treat a medical condition, so please ask your healthcare practitioner before implementing any new treatment.
Good morning, good evening, everybody, and welcome to Dr. Brad Leech today. I'm so honored to have you here today, Brad. Thank you so much for being with us.
It's a pleasure to be here.
Oh, thank you so much. Bienvenue, benvenuto. This is going to be, translated into Italian, French. So you're talking to Europe today, Brad.
That's fantastic. Awesome. I've always wanted to learn Italian and French.
Oh, that's awesome. That's awesome. So let's get started. You're the gut specialist, one of the main gut specialists. And I would like to start by asking you what made you get so specializing into gut and leaky gut. So what was the beginnings of everything?
I got into this profession at a very young age. In fact, I actually dropped out of school at the age of 15 to pursue a career in traditional Ayurvedic medicine. So my first qualification was in herbal medicine, utilizing the traditional philosophies from India. Now, for those who understand Ayurveda, they will say, yes, all disease begins in the gut. It's a very fundamental concept within Ayurvedic medicine that disease stems from the gut. Now, I went on to complete numerous other degrees in nutrition and so forth. And it was when I came around to doing my honours degree here in Australia, I really wanted to, and I said this to my honours supervisor at the time, I want to find the cure for autoimmune disease. And my honours supervisor, Dr. Amy Steele, a good friend of mine and colleague, she looks at me and laughs, and she goes, Brad, this is an honours, this is your PhD. You're not going to be able to find the cure for all autoimmune disease. She says, you need to narrow it down into one small, tiny component. And I said, hey, I read this research article from Professor Fasano over in Italy about the connection between this protein zonulin, leaky gut, and autoimmune disease. And he proposed, this was in 2012, that if we can modulate and prevent permeability, then that may stop the development and exacerbation of autoimmune conditions. So I said, great, let me just focus on intestinal permeability. Now, I focused on this subject for both my honours and my PhD research. So the better part of 6.5, 7 years, all I did was look at leaky gut intestinal permeability, and I was involved in a number of different research projects, and we eventually published and developed what we refer to as the IP guideline. So this is a clinical practice guideline for practitioners to utilize when it comes around to the management of intestinal permeability in their patients. So my research involved everything from looking at how to identify intestinal permeability, how to treat it, major contributing factors. So we did systematic reviews looking at what are the risk factors for intestinal permeability, how are they linked with the clinical presentation, the prevalence, basically you name it, we looked into it with intestinal permeability. Yes.
Thank you. This is amazing because as far as I remember, so I've been in practice since 2007, and I remember, then leaky gut was something that not everybody really believed in, right? So even doctors are like, no, leaky gut, this is a naturopath. They're talking about leaky gut. The gut is not leaking, right? Or it's naturally leaking, but not over leaking, right?
Mm, mm.
But you found a lot of research saying actually that no, leaky gut
And
is a thing. Yeah.
it's an interesting concept here. So I think this really stemmed this misconception from we as practitioners referring to it as leaky gut syndrome. There is no such thing as leaky gut syndrome because a syndrome is a group of clinical symptoms which indicates a diagnosis. There's no group of clinical symptoms to indicate intestinal permeability.
Good.
In the hospital, there is quite acute permeability, and this is established in the research in relation to burn victims, HIV, pancreatitis. But then within clinical practice, what we would see is like this low-grade chronic permeability, this low-grade gut, this leaky gut. And so it's slightly different. I think GPs are, maybe not GPs, within the hospital setting, they acknowledge that it is a thing, but maybe not to the degree that we acknowledge it within clinical practice.
Well, thank you for making this, clarification. This is really, really important. So tell us, what is the definition? How do you define, what's the definition of IP, of intestinal permeability?
So intestinal permeability or hyperpermeability or leaky gut, we can use any word to describe it. I have a preference of not calling it leaky gut syndrome, but I use the term leaky gut all the time. So leaky gut is where the cells in the small intestines, so not large, but small intestines, disassemble from the release of a protein called zonulin. Now, this disassembling of tight junctions, it causes a leaky barrier. Something to consider is, this is only a very small leaky barrier. There's no like influx of the food that we've eaten into the bloodstream, because if that happened, then there would be sepsis and we would die. It's only a very small permeability, but it does happen, and we've seen this within clinical research, within in vitro studies. So definition of intestinal permeability is this disassembling of tight junctions within the small intestines.
Okay, good. And does it happen very often? So it can happen to anybody to different degrees, or what do you think? Yeah.
So we conducted a systematic review to look at the prevalence of intestinal permeability. What we concluded was in conditions that are associated with leaky gut. So these conditions were IBS, autoimmune conditions, liver-related conditions, those types of conditions. So in those, the prevalence is about 1 in 3. 1 in 3 patients that present with one of these associated conditions will have permeability when you measure it. Now, for these individuals, their permeability may come and go. And even for you and I, there's been studies looking at inducing intestinal permeability in healthy adults. And we can actually induce this permeability in healthy individuals. The key difference here is in somebody who is healthy, they will be able to have this increase in permeability and then bring it back to normal. But in other individuals, there is this increase in permeability and it stays there, and that's when problems arise. So it's quite normal, almost to the instance of pregnancy. So a normal mechanistic action during pregnancy is an increase in permeability to support with the development of the fetus. That happens during pregnancy. When we get a bacterial infection in the gut, we will get permeability because it will bring in fluid into the bowel and it will help to flush it out. That's the diarrhea. That is permeability in its essence.
So, okay. So that's really interesting. So, I work with a lot of SIBO patients, so small intestinal bacterial overgrowth, and I think there are a lot of intestinal permeability, cases there because there's more inflammation. And I think, there's a big connection between inflammation and leaky gut, right?
Yes. So we did a systematic review and we looked at all of the risk factors for leaky gut. We looked at everything from gut-related symptoms to biomarkers to bacteria in the gut, you name it. We looked at it. Honestly, it took me about a year to do this study. I looked at over 22,000 research articles to collate all the data. What we concluded were the risk factors for intestinal permeability were not gut-related, in the sense of they're not the classic bloating and indigestion and reflux. It weren't those symptoms.
Yeah.
The factors that were linked with the strongest amount of evidence were markers of systemic inflammation, intestinal inflammation, markers of glucose metabolism disorders, so a high HbA1c, a marker of looking at glucose over a 3-month period, fasting glucose, fasting insulin. Also, disease severity was a potential risk factor that may contribute to the severity of permeability. So when someone had a flare-up of maybe SIBO, maybe inflammatory bowel disease, the degree of their permeability actually increased quite significantly. So it was quite interesting. We actually concluded that intestinal permeability resembles more of a metabolic-like syndrome rather than symptoms situated within the gut. And I know historically, you and I and other practitioners, we would think permeability would be thinking about gut-related symptoms.
Yeah,
but
and intolerance, right? Food intolerances, food allergies, even, yeah?
Food intolerances, I do see quite a lot
You do
with
see, yeah.
especially when we do a test and it's that classic, it comes back and there are 50 foods mounting an immune response.
Right, yeah.
I see that, I'm like, yeah, this is permeability.
Okay.
That's indicative of that classic.
But that's so interesting what you're saying here, Brad. Really, like looking at other markers within the body that actually are linked to intestinal permeability. That's really, really
from a research perspective.
Yeah.
I don't overly utilize them within clinical practice. So I don't utilize, high fasting blood glucose as an indicator for permeability, because we have many other more reliable markers to identify permeability within clinical practice.
Sure. Okay, but maybe you just keep those other markers in the back of your mind, right? And maybe,
Exactly.
Yeah. Okay, that's awesome. Really good. So talking about tests, what tests do you normally recommend? And keeping in mind that maybe here in Europe, we don't use a lot of the lactulose mannitol test, at least I don't. But yeah, tell me, what do you think? What do you think, and what research says that they are the most beneficial tests to use? And yeah.
What we know is there's no gold standard when it comes around to measuring for intestinal permeability. Every method of analysis has its caveats and its potential downfall. So we need to measure multiple markers to give us an indication of what could be driving this permeability and that state. So you mentioned just before this lactulose mannitol test. Now, this is quite common in Australia, but for someone who specializes in gut health, the microbiome, permeability, autoimmune disease, I very rarely utilize this test. The reason why I don't utilize this test a lot is when you look at the literature on how this test is accurate, the accuracy of this test, it's quite conflicting. So for those of you who aren't aware, this test in Australia involves the consumption of 2 sugars, lactulose and mannitol, a disaccharide and a monosaccharide. You collect the urine for 6 hours after an overnight fast, and you look at the ratio between the two, and that will give us an indication of permeability. But there are multiple studies out there to show that the length of time that we're collecting urine is too long. And the test here in Australia is collecting urine for 6 hours when there's research to indicate that it should be collected for 2 to 4 hours. So that's one factor at play. Also, other confounding factors such as medications, the bacteria in the gut, and so forth. So that has its limitations. So I don't actually utilize it that much within practice. So
Okay.
I utilize a lot of stool testing within
Yeah.
clinical practice. So a lot of you would be familiar with zonulin.
Of course.
Zonulin is this protein. Now, probably 2 or 3 years ago, there was a bit of a backlash and outrage about zonulin. And there was this particular study, it came out of New Zealand, and I've spoken to the researchers where they actually found that the commercialized test for zonulin doesn't actually measure zonulin. It measures zonulin-like proteins within that zonulin family. So there's a bit of like oh, hold on, what are we actually measuring? But the simple fact is these, although we're not measuring that particular zonulin protein, we're measuring other proteins within the zonulin family, which we can still utilize within clinical practice. So there's no issue utilizing the stool-based zonulin test. Now, caveat here is we should never be utilizing serum-based zonulin to identify permeability. I've shown this multiple times in my research. We can't use serum zonulin to indicate permeability. There are so many confounding factors because zonulin as a protein is released from adipose tissues and the liver and the heart and you name it. So looking at the blood, it could come from...
It could come from any other organ. Okay. Whereas the stool test, zonulin, is reliable. So we can use that one.
It's reliable, but there's a few caveats here.
Okay.
The caveat is, now this is
a
good friend of mine, Dr. Jason Hollowick. We discussed this topic quite a lot in relation to the accuracy of stool zonulin. Stool zonulin is measuring acute intestinal permeability. So zonulin is an acute phase protein, meaning it has a relatively short half-life, right? So if I stimulated my zonulin, whether that was from exercising or stress or the wrong bacteria in my gut, but then I corrected it and I measured my gut in a week's time, zonulin wouldn't be high, okay? Even if I still had permeability, because I'm not actively stimulating this protein to be released.
This is very interesting, Brad. Yeah. Thank you for specifying this because actually sometimes, can this happen also in chronic conditions, do you think? Like someone that has a chronic long-term digestive condition who has a very high secretory IgAs, but zonulin looks okay?
Yes. So just because zonulin is within range, it doesn't mean we as clinicians should rule out permeability. It's just saying that it's not actively being stimulated at the time of measuring the test. So we've got to utilize other markers to allude to, is there permeability? Now, these could be things like LPS. So LPS or lipopolysaccharides, it's the outer of particular bacteria, which has been linked up with permeability. Now, here's going to be the next caveat. We can't utilize blood-based LPS.
No.
The reason I say we can't utilize blood-based LPS is there are different types of LPS. We have hexa-LPS, which is a very pro-inflammatory subgroup of these lipopolysaccharides. But then we have other LPSs, which are actually supportive of the immune system. So the most accurate way to measure LPS is by looking at the bacteria that produce hexa-LPS. So these are going to be like your Klebsiella, your E. coli, your proteobacteria species producing this, this component that drives up permeability, drives up gut inflammation and systemic inflammation. That is probably one of my biggest indicators. And it doesn't just allude to, oh, there could be intestinal permeability. It's providing me with an understanding of what's the driving factor? How do I actually address the permeability at the cause? And that is because of the wrong bacteria in the gut. And there's many others. Butyrate we can utilize to allude to, is there permeability? Even markers like, and this is quite a novel one, which is quite difficult to measure, but IPA. So IPA stands for 3-indole propionic acid. It's a real novel marker which can allude to, is there actually permeability within the gut?
So that's very interesting. And of course, secretory IgAs as well.
So secretory IgA is an
How do
interesting
you?
one. The research shows that high secretory IgA has a positive correlation with zonulin, meaning that as zonulin increases, so does secretory IgA. So that's one factor at play. Often when I see high secretory IgA, I'm thinking that there are pathogens or pathobionts or other bacteria stimulating an immune response within the gut. And so it's really important when we see high secretory IgA to go, why is it high? It's more of a indicator that there's permeability rather than the cause of the permeability.
Sure. Yeah.
Yeah.
Okay. So let's talk about what are your, of course, there are many nutrients that we can use to correct, to reduce increased permeability. There are just a few that you would like to mention. What are your favorite ones?
Yep. So I will go off the evidence. So when we conducted this guideline for practitioners to follow, we looked at all of the different treatment methods from dietary modification to lifestyle modification to prebiotics, probiotics, and nutrients and supplements, you named it. We looked at it. What we concluded, the 3 supplements with the highest amount of evidence indicating their profound impact on leaky gut were glutamine, zinc, and SB, also known as Saccharomyces boulardii.
Yeah.
They are the 3 with the greatest amount of evidence. A few caveats here is glutamine needs to be at a therapeutic dose. It needs to be anywhere between 10 to 15 grams per day, short term.
Yeah.
So taking it as a token 500 milligrams or 1 gram per day isn't going to have that desired effect.
Yeah.
The SB 250 micrograms, milligrams per day, and then the zinc at least 25 milligrams per day of those. They would be my top ones because I base it on evidence. Now,
and you're talking about just normal zinc, or you're talking about zinc carnosine, or
zinc carnosine has the research to support it.
Yeah.
Other newer interventions which have come out since publishing these guidelines are going to be things like HMOs, so your human milk oligosaccharides, these prebiotic fibers found in breast milk, which we can now take as a supplement. They support with the production of mucin in the gut. They actually modulate tight junctions within the gut, and they feed up beneficial bacteria. And then, of course, identifying, and this isn't a nutrient, but identifying the cause. So if it's inflammation or the wrong bacteria in the gut, and then targeting treatment aimed at that. So if there's inflammation, curcumin, aloe vera, to really target that.
Sure. What do you think about the use of glutamine, and maybe contraindications in cases of, cancer or other conditions? Because sometimes I can hear practitioners, particularly here in France, that they're really very careful with glutamine. So what do you think of that?
It comes down to the dosage of glutamine. So a lot of the conflicts when it comes around to medication are much higher dosages. And that's why I gave the caveat of 10 to 15 grams short term. I once had a patient who came and was taking 20 to 30 grams of glutamine every day for years and years and years. And I'm like, whoa, this is a lot of glutamine. Let's take a step back and actually reduce that amount. So very cautious. Rule of thumb here is 2 hours away from any medication to prevent any interaction.
And short term would be what, 2 to 3 months for you, even 6 months?
I wouldn't do 6 months. I would probably, between 2 to 3 months short term when it comes around to glutamine, and definitely checking kidneys to make sure they are in optimal health.
Yeah, that's right. It's very important because it is interesting when people look, and even practitioners, we look at scientific research. Sometimes it's hard to understand, okay, what are they saying? They're saying yes, they say no. What is this? It's all conflicting, right? And so sometimes it's like, oh, no, I don't want to, recommend such or such nutrient because I can't understand if it's good or bad. So, yeah. So thank you for clarifying this point. What are now the worst thing that we can do to induce leaky gut?
There are a number, and the first one is going to be alcohol. Alcohol induces permeability. I have seen it multiple times in clinical practice, and the research behind it is it's relatively strong. They did one study where taking a equivalent to one standard drink induced permeability in healthy individuals. So alcohol, if somebody has permeability or indications of permeability, let's bring them off the alcohol. And let me go on the record here. In 10 to 20 years' time, we will view alcohol the same way we view smoking. Now, I understand Mediterranean style diet and there's a little bit of red wine. Maybe that's going to be the exception, but binge drinking and excessive alcohol consumption is bad news for the gut and is bad news for permeability. So that's going to be number one. The next one is high intensity ultra marathon exercise. So there are a number of systematic reviews to indicate that high intensity exercise or long duration of exercise will actually induce permeability. Okay. The next one is going to be NSAIDs, so your non-steroid anti-inflammatory drugs.
Sure.
These medications are used within research setting, both in animal models and in human studies, to actually cause leaky gut in healthy individuals, right? So they are another one. Now, I might want to do a bit of myth busting at the moment and mention gluten.
Yes,
so I know this is a very controversial topic around gluten and leaky gut. And I know it's controversial because for many, 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 many years, I was saying gluten causes leaky gut for many years. Okay. And this stems from a number of research studies where they got petri dishes of cell lines of healthy individuals, celiac individuals, non-celiac gluten sensitive individuals, and they placed gluten on it, and they noticed that permeability was induced on everyone. But it was really interesting. Within my guideline, we actually identified a number of studies that looked at gluten in individuals and actually found that it was more of a threshold of gluten that an individual with permeability could actually tolerate and still be okay. I've actually seen this in case studies where I've prescribed rye bread, so a form of gluten, to a patient with elevation in zonulin and other markers, and their permeability improved while consuming gluten. So I don't think we should view gluten as the end of the world, but the caveat here is if somebody is in a flare, whether it be inflammatory bowel disease, whether it be SIBO, whether it be food sensitivity, where they're reacting to everything, yeah, let's pull back on the gluten. Sure. The other caveat, exactly. The other caveat here is going to be the quantity of gluten. It's going to be the type of gluten. Is it a organic sourdough piece of bread on a Sunday with brunch with your friends? That's going to be fine. But having gluten every single day in the form of, and I usually say Domino's or Pizza Hut, I don't know if you have them over there in Europe, but fast food, highly processed gluten, that's going to be...
We have croissants here. And baguettes. And baguettes and all these things. Yeah, of course. So common sense, of course. And okay, so that's I think the common, the worst enemies. Of course, alcohol is the biggest one. Yeah.
Massive.
It doesn't surprise me. Yeah. So what is the role of probiotics? You mentioned already one of the prebiotics. Do you use much of the probiotics, or what's your take on those?
So we looked at this in our guideline, and we looked at every single human study that utilize either pre or probiotics. And unfortunately, we actually had to conclude that pre and probiotics had insufficient evidence to be prescribed for permeability. But that's just looking at human grade research. In my discussion section, I basically explained that we are limited by studies not accurately measuring permeability, thereby we can't use those studies, or but studies where they didn't use a high enough dose of probiotics, or they used the wrong strain of probiotics. I utilize a number of very effective strains of probiotics when it comes around to permeability. So I mentioned SB just before. Another one would be Bifidobacterium BB12. That's got some research to support the gut and to support with permeability. The thing to consider here is, could the probiotic be used to treat the underlying driving factor? So if we treat the underlying driving factor, permeability will improve. So we've got research to show when we prescribe prednisone to Crohn's disease, permeability improves. That is not to say that prednisone improves permeability, but it improves the underlying condition, the Crohn's disease, and thereby the Crohn's disease doesn't induce permeability, it improves. So give the example of Lactobacillus plantarum 299V, a very common strain used for IBS. If we treat the IBS, permeability may improve. So prescribing a specific probiotic strain for a targeted reason is an evidence-based approach for utilizing them for intestinal permeability.
Sure.
When it comes around to prebiotics, we need to feed up the gut. There are so many patients that I see that have a lack of microbial diversity. Their microbiome is just compromised. And because their microbiome is compromised, that's going to be driving permeability. So we can utilize targeted prebiotics to feed up the microbiome. I'll give you an example here of GOS, GOS, galacto-oligosaccharide. Now, a lot of your SIBO patients, if you prescribe this to them, they would react and they would say, why are you causing me even more bloating? Because it is a FODMAP. But in the non-SIBO, non-FODMAP sensitive individuals, GOS can be a very effective intervention to bring down hex-LPS, one of these driving factors behind permeability.
Sure.
So,
I actually use quite a lot of not GOS straight away, but PAGG, quite a lot, even with my SIBO patients, especially with those, with methane SIBO. IMO?
Yes.
Yeah.
The other one here, there's particular strains of probiotics that can be used for methanogen overgrowth. So particular strains is the Lactobacillus rhamnosus DSM, which has been shown in the research to bring down methanogens within the larger bowel. And if we can address that underlying maybe SIBO picture, that's going to be a beneficial thing when it comes around to intestinal permeability.
Yeah. That's awesome. Yeah. So really specific strains for specific, presentations and conditions, of course. And what else? So how do we keep in touch with you as practitioners? What can we do to do more of your courses, to get more of your wonderful research out there? So
yeah, definitely. So you can look me up at drbradleech.com. That's LEECH. On Spotify, I think I've got about 30 plus hours of podcasts that you can listen to. So you just type in Dr. Brad Leech. And then also on YouTube, Dr. Brad Leech. And I run a number of educational events, whether it's in person at conferences. I feel like I'm always talking about the gut and the microbiome at conferences. And I also I run a 6-month mentor program aimed at practitioners to upskill them in the area of microbiome, and then how can we address the microbiome? How can we really support our patients to have optimal gut health? And in fact, in the round that is currently happening, so it happens every 6 months in July and January, I've got 2 or 3 practitioners from France and that European Union. So there are more and more practitioners finding me over there in Europe.
Well, that's
which
awesome.
is
That's
great to
awesome.
see.
Yeah, and hopefully more, because we need more practitioners that trained with you. And what do you do for patients? Do you also have courses or things for patients?
With patients, I've got a number of courses which I've developed for other institutions that patients can do. It's one of those, as you would know, as a practitioner and somebody that's creating content, you've got all these great ideas. I have a course sitting there ready to go for my patients, and I just haven't found the time to actually just implement it and put it online. But I work with patients one-on-one, seeing them as a practitioner.
Sure. Well, so many things, so many projects, right? And maybe a book on
Maybe a book,
maybe
who
a
knows?
book.
I might need another holiday to write a book.
And of course, we can read all your wonderful research, scientific papers that you have published during the years. Those are amazing. Thank you so much. So how would you like to conclude this wonderful interview today, Brad? What's your take-home message?
My take-home message when it comes around to managing leaky gut in clinical practice is always look for the cause. Always understand what is the driving factor between the patient's or for the patient's permeability, and ensure that you're addressing that. If it is a increased expression of tight junction proteins within the small intestines, great. Utilize glutamine and SB and zinc to tighten those junctions. But if it's more from disease severity, like in inflammatory bowel disease, treat the underlying condition and permeability will resolve.
That's awesome. That's really good, because sometimes people, I think, even sometimes practitioners, maybe we get stuck on, oh, we need to, treat leaky gut, but actually what is causing leaky gut? So that's the most important thing to have a look at. Well, that was so awesome today, Brad. Really, really grateful to have you here with us. I think our audience will love this, all this amazing information that you share with us today. So I'm really thankful, and maybe we will see you again for more news on leaky gut soon. Why not?
Sounds good. Let's do part 2.
Thank you so much, Brad.
See you.